Good afternoon, everyone. We'll do it again. Good afternoon, everyone. All right, yes, this is the policy, this is the Academy. So we're glad you're here. I'm Jeri Milstead. I'm a member of the Planning Committee and also the Development Committee. And I have two responsibilities today. I want to introduce Dr. Mcginnis, but before that, I want to remind everyone here about what policy is. It is not equivalent to legislation. We think of policy, we think of laws and bills and legislation. It's a much broader process. Policy, if you look at it as a functional kind of thing or a structural kind of thing or a process kind of decision making, it involves components that include agenda setting. How do you get your important question or the thing that has been niggling at you in the back of your mind, how do you get that to the attention of government? There are many ways and ways to keep it on the attention of government, because the policy is the president's policy at the federal level, the governor's policy at the state level, and so on. A second component is what is the government's response? Often that is legislation, but it could be regulation, and Lord knows, we as nurses know about regulation. We are regulated. Our licenses are regulated, our practice is regulated. That's another important component. And it could be presidential directive. A third component is actually policy design and program design. How are policies and programs designed? How are they implemented? And how are they evaluated? And that evaluation piece can become very crucial to continuation or termination of a policy or a program. Sometimes it never gets done. So as you sit through these programs the next several days, see if you can ferret out which part of the policy process we're addressing in which component, because we've all been alerted to there are many, many parts. It's a broad process. It's a process of decision making, and it's a process in which we as individuals and groups have a great deal to say. Now, to my really fun part, Dr. Michael Mcginnis. Dr. Mcginnis is a senior scholar at the National Academy of Medicine. He's a Leonard D. Schaefer Executive Officer and Executive Officer of the Academy's Leadership Consortium for a Value and Science-Driven Health System. As an elected member of the National Academy, he has worked with previous administrations at HEW and HHS, remember HEW, with policy responsibility through the Carter, Reagan, Bush, and Clinton administrations. So we have decided at the urging of the board, and rightly so, that we will not take up a lot of precious time with introductions. We have wonderful biographies in the book, so do check those out and read them carefully because our speakers are phenomenal. It is my pleasure to introduce Dr. Michael Mcginnis.
Thank you.
You're welcome.
Well, thank you so much, Jeri. And thanks also to Kay and Karen for the lead-in. Special thanks to Kay for many years of partnership in our work on the broader public health arena, and for her calling me to invite me here today, because this is a very special treat for me. One of the things that she mentioned was that I am from the National Academy of Medicine, which is part of the National Academy of Sciences, Engineering, and Medicine, your sister academies. And we were created in 1863. What she didn't mention was that we were created on March 4th, 1863, and it was on March 4th, 1863, that the request to create a National Academy of Sciences, the bill to authorize the National Academy of Sciences, the vote to enact the Charter of the National Academy of Sciences, and the signature to set it into place happened on one day. Congress and our policy process has changed a bit since that time. And I don't think I'll be going out on a limb to say not much for the better. I'd like to also express congratulations to Suzanne Miyamoto on her selection as the Academy's new CEO. And of course, thanks to Mary D. Hacker for the stellar interim service. I'd also like to offer congratulations to Eileen Sullivan Marks, your incoming president, who I had the pleasure of having dinner with, along with UCLA Dean Linda Sarna, an old-time friend of mine, on Sunday night. Eileen, congratulations and welcome to your new post. As I mentioned, I really am deeply honored to be with you today and to help to launch your discussions on the theme of leadership in developing and sustaining health policy. This is a most enjoyable privilege for me. I've been long blessed with wonderful colleagues going back to when I was in Knickers and my good friend Linda Sarna was just out of the crib, I believe. You know, I've always wanted to say, when I was in Knickers, I don't really know that I'm sure what Knickers are, but it was a long time ago. And I have to say, with respect to the nursing community colleagues, there's no honor of which I'm more proud, or frankly, and admittedly less deserving, than my honorary fellowship in the American Association of Nurse Practitioners. I should also note from my platform at the National Academy of Medicine that we do have 17 deans of medicine in the National Academy of Medicine, but we have 6 deans of nursing as well. And we learn a lot, and I would venture to say, given the impact of what I see with folks like Tony on our council, that the nursing contribution is more important in many ways than any other single component of our academy. So we are very indebted to the American Academy of Nurses, and I should probably also emphasize that our bestseller for many years running now is the Future of Nursing report. So we feel gratitude in every dimension. And by the way, stay tuned for later in the meeting, more discussion about the next steps in that respect. So thank you for inviting me. Thank you for allowing me to noodle with you about a topic that's very important here in Washington. Why science and evidence are important to health policy. At first blush, this notion of the importance of science and evidence to health policy seems self-evident. Doesn't everybody know that science and evidence are important to health policy? Isn't this pretty basic? What else is there to say about it? Well, drilling down, what you're actually asking are several questions. You're asking, are science and evidence important to policy, the basic question. You're asking, what happens when science and evidence aren't the core pillars of policy, the circumstances? You're asking, why does strong evidence often yield weak action, the factors in play? And you're asking, what can we do to strengthen the hand of science and evidence in policy formulation? All of those are critical issues, and more critical than ever now in Washington and really in every public arena throughout the nation. And I'd like to emphasize what Jeri mentioned, and that is policy is not just about voting. In fact, policy has a very broad reach into every aspect of our society, whether it's the notion of zoning laws or the notion of how we structure our assistance programs, or even the notion of whether we build and require physical education in our schools. It extends throughout every aspect of our daily lives, and it's important to keep that integrated picture in mind as we take on individual aspects on a daily basis. Because the basic question is, are science and evidence important to policy, let's talk a little bit about what basics are. And to illustrate how basics, a basic set of circumstances will be, or can be, I'm going to start with an example of a woman living through a war in Sarajevo. It's a story about Mirza's mom. And there can be nothing more basic than trying to survive through a war situation for a 4-year period. In 1995 and 1996, as the Dayton Accords were establishing a truce in the Bosnian War was being negotiated to a conclusion, I served in Sarajevo as the chair of the World Bank European Commission Task Force to rebuild the health sector. The Bosnian War was a 4-year nightmare of ethnic atrocities that accompanied the breakup of the former Yugoslavia, wrenching apart neighbors, friends, family members, and introducing, at least to me, the most heinous of euphemisms, ethnic cleansing. In some areas, one could drive mile after mile after mile past deserted villages whose residents, solely because of their ethnicity, Muslim or Croat, had been expelled or killed. In every war, there are civilian casualties, but this was a war in which the primary targets were civilians. And over the war's 4 years, 3/4 of the population was displaced and 200,000 people were killed. Mirza Djurdjevic was a young medical student. His studies had been interrupted by the war, but he'd found work in our office in Sarajevo, a UN office. And Sarajevo, you may recall, was a divided city during the war, with Serbs in control of one side of the city and its suburbs, and on the other side, largely in Muslim control, with the two sides divided by the river Myopia. This is the Latin bridge which spans the Myopia River going through Sarajevo. And those of you who are history buffs may recognize this bridge as the bridge where on June 28, 1914, Archduke Franz Ferdinand of Austria and wife Sophie were assassinated, starting World War I. If you imagine about a half a mile to one side and about a half a mile to the other side, you'll imagine a closely proximate geographic area with two warring nations separated only by that bridge. And I want to talk about the significance of that in just a second. Sarajevo was destroyed largely by the shelling from both sides going across. Olympic housing was reduced to empty high-rise shells. Some of you may have been to Sarajevo during the Olympics, although that was quite a while ago. I think I might be the only one old enough here to have been to the Sarajevo Olympics. But the windows and walls of those housing projects that housed the Olympic athletes were blown out. The stadium fields were converted to makeshift graveyards. Hospitals took their operating suites underground and built new reinforced walls up the length of the building or the height of the building in order to ensure that the patients on the other side were safeguarded. My own apartment was in the center of Sarajevo. It had plastic sheets for windows because they had long since been blown out, even though there was not active fighting at the time. By the time I arrived, the bullet holes were still in the wall. There was no gas and no electricity. Running water was restored at that time for just a few hours a day, so we filled everything up in barrels and enough to last us for a couple of days. Slowly, as peace took hold, different parts of the Sarajevo suburbs were reunited under a common jurisdiction. And in March, 4 months into my tenure, the snow was melting. The tanks were making way for the return of cars to the streets. With spring blossoming, the smell of hope was beginning to seem real, and the last of the Sarajevo suburbs that had not yet been united were pulled together under unified control. On the day that the bridge opened, when everything was now unified under one jurisdiction, plenty of tension, but one jurisdiction, Mirza came to me and he asked if we could use one of the UN jeeps to cross to the suburb just on the other side to visit his mother, just on the other side of the bridge. She's a doctor, a Muslim doctor who lived in the Serbian sector and had lived there for 4 years without being able to see her son, despite the fact that there was a little more than a mile between our office and her apartment. So it took us a very short time as we drove over there to find the building, a 7 or 8 story structure. It was heavily damaged and largely abandoned. We made our way up the staircase. The elevators had long since been broken, past apartment after apartment, abandoned and destroyed either by shelling or sabotage during the evacuation. Mirza's mother's flat was on the 2nd floor from the top. We knocked, and you can imagine the sight of the reunion between mother and son. After the initial moments, she turned to me and offered me some coffee. And I naturally, not thinking twice about it, accepted. And she then proceeded to go out onto her balcony and pull together some twigs, light a fire to boil the coffee. And that's the way she lived for 4 years, scraping together whatever she could to help herself go on. And ultimately, she prevailed. So I asked Mirza's mom how she'd made it through these 4 years, and she said, in effect, 1, I kept my focus on the truly important. I knew the terrain. I knew the incentives in play and used my strength to try to shape them. The faces served as my guiding stars. I forged partnerships to strengthen my position, and I never let my spirit flag. And when you think about it, and one can't help but think about how she survived in her circumstances for 4 years, what Dr. Djurdjevic did was practice under duress the same basic principles each of us needs to bear in mind as we seek to place evidence and science in the strongest position to shape policy. She kept her focus on what was truly important. For her, the important was not just surviving. Her clear source of inspiration was her ultimate reunion with Mirza, and that gave form to her choices and their priority. She knew the terrain and what she was up against. A Muslim in a Serbian world, she spent many of the early months of the war getting the lay of the land, who were the key players, which sections were controlled by whom, where was the major shelling occurring at what times, who seemed to have the best information, basic surveillance in health parlance. She knew the incentives in play and used her strengths to shape them. What were the rules of engagement? What were the motives of those in her vicinity? What were the primary needs, and how could they be matched by her strengths? This was fairly straightforward. A physician in a war zone, she had the ability to help widely in an environment where the primary threat was to life and limb. The faces served as her guiding stars. Mirza, of course, remained the clearest face in her mind's eye, but those of others with whom she came in contact sometimes reflected a special spark, a spark that inspired not only hope and trust, but also creativity, which was certainly required in a situation with such limited food and supplies. She forged partnerships. As familiarity, trust, and understanding grew, she carefully identified people around her with common interests. She forged partnerships and worked closely to nurture the strength and the trust of those bonds. She never let her spirit flag, at least in any obvious fashion. She tried to frame the daily struggles with uncertainties, the logistics, the various individuals as de novo challenges, problems to solve, natural elements on the path to her goal, and she would not allow herself to be discouraged. These are words to live by, words to guide our pursuit of policies that can make a difference. In her case, she was successful in reaching her goal. She used her knowledge very well. Just as you, in your pursuit of the policies that can make a difference throughout society and America's health, can use nursing knowledge and the knowledge that you've accrued in your various activities very well. But let's take a look first, before getting into the issues at hand, at what happens when policy doesn't take advantage of the evidence. You know, there are a lot of examples. Some of them are small, some of them are very large. Many of them are well known to you from your own activities and leadership in the policy arena. So let's look at the biggest ones, the biggest consequences for the health of Americans and the American people. What happens when we ignore the evidence, and evidence that we have long known in many cases about what shapes the health of Americans? The determinants of health. Now, 40 years ago, I had a faculty member say chronic diseases are just inevitable consequences of the aging process. This is by now second nature to you. We now know that health is determined by issues related to our genetic determinants, our social circumstances, our behavioral choices, and the medical care we receive, and that the medical care we receive is relatively limited in its overall impact for the health of society. But of course, even more important that we've now learned even more recently about is the importance of the determinants intersections. What happens at those intersections that shapes the health of populations and shapes the effectiveness of our interventions? And of course, an important question, since we now know these issues, science and evidence has told us what's important, both about the domains involved and about the importance of the intersections. How do we devote our spending? Well, of a $3 trillion health budget, if we can count all health expenditures as a budget, over 90% of that budget goes to treatment of acute conditions, and often to high technology intensive interventions, which may or may not work. In some cases, we know when you're ill and when you have a serious condition that is threatening your life, nothing is more important than medical care, unless it's the right medical care, which is critical, and it's the experience that you have, that you study throughout your institutions, and that you inform the nation about, that can help improve the effectiveness of those investments. But right now, our investments are not effective in terms of the quantum of efficiency. And we know that about 30% of our investments are unnecessary. In fact, it's a low estimate. You see here some data that are a few years old, but the proportions remain relatively similar. And that is that of our $3 trillion of health expenditures, about 30% are unnecessary, and they're distributed among different categories: unnecessary services, inefficient delivery of services, excess administrative costs, prices that are too high, missed prevention opportunities, and fraud. So the consequences of ignoring the evidence about what works best for whom, under what circumstances, not only in the medical care arena, but in the other factors that shape the health outcomes of individuals and the social justice of those health outcomes, clearly are important consequences. The question, as we learn more and more and accumulate more and more evidence about societal and individual susceptibility to the impact of the intersections involved, is do we have the societal will to invest where our investments really can make the most difference? Or is it simply just a challenge of too complex a set of circumstances that really can't be addressed through policy decisions? Well, not for some nations. In fact, we're outliers in that respect. And you see here Elizabeth Bradley's analysis on the vertical axis is expenditures as a percent of GDP, and on the horizontal axis you see different countries. And the red circle indicates where the U.S. lies. And the total investments here are the key issue, because you're probably surprised that when we're talking about investments by different countries in issues that are important to health expenditures, that we were talking about medical care expenditures. Well, we're not. We're talking about medical and social expenses, those investments in the health of populations that can make an aggregate difference. And you see that we're sort of in the middle of the pack when it comes to investment profiles of that sort. Although if you look in the blue portion, that indicates how much we're devoting to the medical care portion. And if you look in the red portion, that indicates how much is devoted to the social services portion. And you see that we still are very much outliers on the high end of the medical treatment portion of that, to the neglect of the social services dimension. And you see what the consequences are for the health of the nation as a whole. We are in the middle of the pack, despite our having twice as much medical treatment expenses per capita as the average throughout the OECD as a whole. So the fact is that policy can make a difference, but it takes will and determination and a lot of knowledge to make that difference. The consequences are clearly not only now for those who suffer from disparities, who are in the lower income spectrum of our population, but they're creeping into other elements of the population as a whole. They're becoming more mainstream, as you see here, with the fact that life expectancy has now shown aggregate declines in the last few years. And the slope of those declines is greater in the U.S. Than in other nations. And the fact is that when we see the widening gap according to social circumstances in the performance of our system as a whole for those with high income and low income, these declines may well be even more dramatic. They certainly are more dramatic now for example, black women and black men. And it's an intolerable development in our society. And it's an intolerable development. It's a consequence of our not heeding the evidence in the science. So why is this? Why is it that, what is it that's causing strong evidence to too often yield weak action? I call these the dirty dozen. These are the factors that are in play that thwart and frustrate our efforts to have a stronger link between science and evidence and effective action. One of them, of course, is the complexity of the issues. It's possibly the most obvious challenge in that when we're dealing with multiple factors that yield health outcomes, we have a little bit of trouble. It's like we can't walk and chew gum at the same time. We have to rise above the simple and begin to engage the practical and the real when we're developing our strategies. We're pretty good, for example, in treating colorectal cancer. It's got a well-established protocol tailored to family history, stage of the disease, and so forth. On the other hand, trying to prevent the problem is much more complex, needing to accommodate issues such as genetic predispositions, dietary and physical activity patterns, access to screening services, even the potential of stress of one's social circumstances. In the fog of complexity, established opportunities are easily ignored. The primacy of the rescue. No story is more uplifting than that of a rescued victim, nor more tragic than that of a failed attempt. Our attention is drawn naturally, as it should be, to the plight of people in crisis. Our moral obligation is both compelling and irresistible to apply every means at our disposal to reach out in compassion to assist someone in a diabetic coma. Yet, much more easily resisted is the equally compelling obligation to apply all available knowledge to promote the programs which could go a long way to reducing the likelihood of diabetes in the coma. Rescue is codified in laws that require it. And yet the codification of the ultimately more effective set of measures remains elusive in our policy construct. Technophilic culture. Society places a premium on scientific knowledge and technological development, and in particular, technologies which can be applied to us as individuals. We're a people who appreciate a technological fix to a problem, and the more novel or dramatic the fix, the more our attention is drawn. Let's choose back surgery over better established, less invasive approaches. Let's emphasize the solo interventionist rather than the therapeutic team with better results and stronger patient satisfaction. Blunted time horizons. We tend to be impatient, yet by definition, the results from investments in social determinants and health equity are separated by time, often years, from the intervention. Human nature and our present-minded culture is to put off today what will not yield results until down the road. Perverse incentives. Our entire reimbursement system is oriented around fee for volume. That's what's led to 30% of our $3 trillion investment being wasted. And the path to moving from fee for volume to fee for value in population health is one that is very circuitous if we can see it at all. What's promising in this respect and gives you a toehold, all of us working together, is that throughout society we have a different set of circumstances than we did a half a dozen years ago. There is now a pretty clear general agreement that we have to move away from fee-for-service to a financial investment system that is much more prone to improving population health and delivering value for individuals and society. Double standards. Because of the duality in the time horizons for treatment and for prevention, as an example, we generally use different standards in our decision criteria for attention and investments. Introduction and application of high-tech interventions generally needs only proof of its safety and its effectiveness, not always the latter. Whereas introduction and application of a continuity of care model must have demonstrated its safety, its effectiveness, and its cost-effectiveness as well. We need to make sure that a level playing field is the anchor element in our policy process. Professional myopia. When the complexity of care is growing so rapidly and the ability to effectively prevent and manage conditions so much more complex, we're well past the time when a single clinician can be as effective as the available evidence would allow. This reality underscores the importance of the team approach previously mentioned, but more than that, it underscores the importance of professional societies working together to forge new, more enlightened team paradigms as the starting point of the care process. Fragmented decision points. Perhaps the biggest challenge for our health and healthcare system, writ large, is its fragmentation. The extent to which our system is divided into individual components that reinforce their separateness presents a tremendous problem in moving to a more rational system. And if you look at the situation of high-need patients, for example, the 5% of patients who drive 50% of costs, the services they require are not just acute clinical services, social services in their communities, home care, education, team across all aspects of the therapeutic intervention. In many cases, the decision points for reaching the individual in greatest need are in totally different departments, in totally different organizations, and the incentives are not in play to link those decisions and those services delivery. So clearly, fragmented decision points is a vital challenge. Vested interests are obviously an issue, and I'm not really talking here about industrial self-interest, ignoring all of the other social goods that need to be engaged in society. For example, tobacco against health outcomes, or the practices of food marketing and the impact on our dietary patterns among kids. Those are relevant, yes, but I'm really talking here about the tendency of both commercial and professional vested interests to contribute to that fragmentation. The levers of progress are fundamentally impaired by the self-interest behavior of those organizations with vested interest. The flow of funding streams is also a challenge, both at the local and the national level. We have to deal with the Department of Health and Human Services, the Department of Labor, the Department of Education, and all the relevant congressional committees, which are linked in very tailored fashion to each of the issues you're trying to address. So there has to be a multi-attribute analysis in order to deal with those issues effectively, and the same is true at the local level. So the flow of the funding streams remains another challenge. Then there's the paradox of self-responsibility. It's the flip side of our technophilic culture, and that is where social and behavioral issues are at work. It's so easy for us to say, well, a lot of this is up to the individual involved. It's not part of our fundamental policy obligation. That's a cultural thing that we clearly need to move beyond. And finally, politics. I won't say any more about this because that's what we hear every day. So what to do? The Dirty Dozen represent formidable challenges. Impressed as I am just going through them, because they are tough. But on the other hand, we know what they are, and we can work together to address them. And just the more we are aware of these factors in play, the more effective we can be in figuring out strategies. So, hearkening back to Mirza's mom, what we clearly need to do to level the field is play firmly to our focus on the important. That is the importance of the big picture and linking what we do in our individual areas to ultimately improving performance in the big picture, while not ignoring selective issues that may pertain only to us, but starting with the notion of what is important for society. How is what we can do and must do important to society? Understanding the terrain, certainly we need to make sure that we are aware of others who have interest in these areas and about the junctional points, ways in which we can ensure that we emphasize where the interests are common, and those partnerships will help strengthen our overall synergy and capacity, moving toward the bigger picture, as well as those particular issues that may be especially relevant to us. The inspiration of the faces, well, stories matter. Regardless of whether you're working up on the Hill or whether you're working with an individual agency, there is no way that's better than telling individual stories that make the point. And there is no profession that is closer to those faces, that has a clearer picture and recollection of those faces than the nursing profession. You can change the game by nursing knowledge in this respect. Working to change the incentives, rather than focus only on the issues that are maybe relevant to us most immediately, the way we can work against our fragmented system is to all of us start with the end game, if you will, and that is a system of continuity of care, of incentives, of team operation, in which the rewards are for improved health for the population, as well as better and more effective medical care, and then backward map to ensure that what we're doing in working on the incentives helps to reinforce the path toward what we're all seeking as a society. Forging partnerships, we've already talked about that. It's obvious, but it's something we do too little of. frankly, a friend of mine long ago once said, coordination is not a natural act. And unfortunately, it's too often proven to be the case. But we are simply not going to reduce the fragmentation that's dragging us down where we should be lifting us up unless we forge those partnerships. And finally, as we heard from Mirza's mom, taking advantage of your spirit. Again, there is no group that has a stronger advantage in this respect. There is no group with a stronger spirit, with a stronger spirit that's understood and perceived and appreciated by the rest of of our fellow citizens than the nursing profession. So you have the opportunity to lift us all up with that spirit. Obviously, I learned a lot from Mirza's mom in my brief interaction with her. And I think we all have much to learn. But each of you in this room has the ability to add effectiveness and power to the kinds of lessons that she imparted. And I very much, for one, am deeply appreciative of not only what I see as your contribution already, but what I know is going to be your contribution into the future. I look forward to partnering with you and to benefiting from your leadership. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you, Dr. McGinnis. We do appreciate those spirited words, and thank you for them. We have a few questions. One first is, will your slides be shared? Will your slides be slared? Yes.
I'm happy to slur them.
Thank you so much. That's a Spoonerism for those of you who are aware. Yes, they will be shared. Thank you. Given the complexities associated with addressing health inequities today, what is the most effective policy work lately at a local level rather than at a national level? How do you see that?
The simple fact is that the major progress against health inequity is going to come ultimately on the front line at the local level. So while we need to have the national air cover with policies that reward, for example, population health outcomes in the health dimension, that break down barriers in the reimbursement arena for medical care services and social services. There are a lot of those barriers. But ultimately, the effectiveness of the application of policy changes that we're moving towards slowly is going to be dependent upon what happens at the local level. And I think what needs to, what we as a society need to be much more aggressive about is ensuring that in every community, the kind of multi-sector community health needs assessment that is undertaken has the key players involved from the social services sector, from the public health sector, as well as from the medical treatment sector. And that the combination of those collective commitments to identify and engage the challenges at the local level based on local community organizations is tracked with a commitment to ensure that data are focused on the most basic issues and gathered in a sustained fashion over time. What I'm getting at here in some ways is that I'm on the board of a hospital, a healthcare system that's big, and a few years back, every 3 years, as you know, with the IRS rules, if it's a nonprofit, you're required to do to show your commitment to community benefits and to do a community needs assessment. Well, the fact that we, I say we as a board member, invested $1 million in a community health needs assessment, and an institution 3 miles down the road did the same thing, neither of them in contact with the public health department or the social service agencies or the key players involved, is a tragedy. There is so much more power that can be unleashed with partnership and shared commitment.
Thank you. And obviously you got a lot of response from those of us here who agree with you. Now, to what extent does the fragmentation in our current U.S. system affect how policies can be related to rectification and justification and injustice?
You mean health equity?
Health equity, yes. And fragmentation versus health equity, how does the fragmented health system, because it is fragmented, it's been fragmented for years.
Oh, well, our fragmented system is a major source of the health inequities that exist. If you have a reimbursement system that has multiple payers within a certain geographic area, which are in poor consultation with each other, either about the challenges in the area or about the need for collective engagement of the social determinants, of moving from inside the clinic walls to outside the clinic walls and ensuring that the bridges exist, the more fragmented the decision points are in order to ensure the seamless connectivity of efforts that are undertaken both outside the clinic walls on the social determinants of health and inside the clinic walls to treat the consequences of our failures to keep to reduce health inequities. The more those inequities are going to be compounded. So whether it's the notion of the way we pay for care, the way we don't pay for some of the fundamental social determinants of health, the way that we treat issues like housing and transportation, there's no greater contributor to health inequity than lack of transportation to whether it's the social services you need or the medical care you need. So one of the reasons that we are so far behind our European and Asian nation comrades, if you will, is that we have a much more fragmented system than is present in any of those countries.
You're speaking to a whole group of well-educated, highly motivated, experienced in many ways, policy nurses. We think of ourselves as doing good things, but there comes a time when you say, how much more can I take on? And I've heard that from so many nurses. I've got a practice to run. I have students to teach. I have administrative things to contend with. I have research that has to get done. I have publication that needs to be published. What do you say to nurses such as this group who are there, who are doing all of these things? How do you do one more thing as far as developing policy?
You mean being active in the field?
Being active in the field. Because a lot of people, I think of just going down to the State House and testifying. It's not quite there, is it?
No, I think the issue is not going down to the State House and testifying. That's just a minor part of the policy process. The first opportunity and obligation is to ensure that the information about key issues in the policy, well, first of all, to identify those most important policy issues from your perspective, which are the levers that you know the most about, that you can make the most difference on. Secondly, to ensure that the knowledge that you have about those levers is augmented by knowledge from your colleagues in the field, so that you're not dealing with only your set of findings, but you're dealing with the aggregate weight of the findings of you and your colleagues. Thirdly, to ensure that that collected compendium of information, and the Academy can be very helpful in that respect, working together to identify the taxonomy of key leverage knowledge bases, if you will.
All right.
And to ensure that you have thought very carefully about the individuals, the identity of the individuals who wield those levers, who make those decisions, and that the information is made available to them. Now, what really requires additional time, most of what I've described should be part of the process of your work inherently. What requires additional time is to strategize about how to do more than just make the information available. It's how do you package it, who gets you in the door, to which doors, and that sort of thing.
Thank you. With that, I think we have to call a halt to our session right now. If we'd please give our applause to Dr. Michael Mcginnis for his thoughts, and thank you all.
Thank you very much.
Thank you.